Okay, good morning, everybody. Welcome back to GIM Grand Rounds. This morning, we're honored to have our Meiklejohn guest lecturer, Dr. Alicia Fernandez, who is professor of medicine at UCSF. She's here to speak with us about language barriers in healthcare. Very glad to have you. Thanks for joining us. Looking forward to your talk.
Thank you very much. I have to say I'm delighted at this invitation and really honored to give a talk named in honor of Dr. Meiklejohn. I heard some about him from Talmadge King, who is my dean and who had been a professor of, who had been here as a pulmonologist for a long time and knew him and was telling me what an impressive, kind man he was. So I am triply honored to have been invited. I thought what I would do today is give you a whirlwind tour through some of where we are. Can you all hear me okay? Great, perfect. A little louder? Okay, let me know because I have a tendency to walk away from the podium. And so please just let me know. And I know that without the microphone, people on Zoom can't hear me. So I would appreciate it. So what I thought I would do today is very briefly just tell you sort of where we are in terms of the demographics of language gaps but then really focused on three issues: on what have language barriers taught us about how communication affects patient-centered outcomes. I want to talk about the very mixed data on clinical outcomes, and then touch briefly on some innovations. And I really hope I tried my best. I really want to have time to have questions, partly because it's hard to cover everything in a talk, and I would be interested in your concerns and questions, and partly because I think it makes for more interesting Grand Rounds, having done my own share of Grand Rounds and been in both places. Let me tell you how I got interested in this. This is San Francisco General Hospital. For some of you who may not have visited us in a while, this is our new building, which was paid for by a bond by the city. And then Mark Zuckerberg and Priscilla Chan gave us money to outfit our old building, which is behind it. Priscilla Chan is a physician and did her medical school and then her residency with us, and has been on faculty at the General in pediatrics for a very long time. So we have been happy with that gifts. It is the sole county hospital for San Francisco County and the sole level 3 trauma center. And San Francisco is extraordinarily linguistically diverse. There are 160 languages spoken per year at the General, about 40 different languages spoken every month. And we provide interpretation in about 38 of those directly through our own staff. And then we obviously use LanguageLine for other interpretations. I am mainly a researcher. I continue to have a panel of primary care patients that I see. I have clinic once a week. And so I have a very small panel. And in my small panel, you can see the list of languages represented. So when I talk about this, you'll notice that a lot of my examples come from Spanish, which is a language that I do speak and is the most common language at San Francisco General. But I face language barriers in my work every clinical session. So so I'm on both sides of this divide. So here's a map of linguistic diversity in the United States. The dark blue states have 28% or more people who speak a language other than English at home. Colorado is sort of in the middle of those. You have 91% of your population, according to the last census, the ACS, and 91% speak only English. And of your foreign-born, 44% would qualify as LEP, limited English proficient, by using the census definition of people who speak English less than very well, the categories being very well, well, poor, or none. In California, it's about 30% of the population speaks a language other than English at home, and a larger number of people who speak English less than very well. Both the amount of people who speak English only here in green has been growing, but so has the amount of people who speak a language other than English at home in the last since 1980. Of those, the most common language is overwhelmingly Spanish. So about 62% of the language other than English at home speaks Spanish. Chinese, which groups all forms of Cantonese, Mandarin, Toisanese, all forms of Chinese, is the next most common with only 5%. And then the numbers really rapidly drop off with all the other languages being less than 1% of the non-English speaking, other language population. So about 8 to 9% of the total population speak English very well. That is an enormous amount. If we grouped everyone with schizophrenia, 1%, everyone with RA, 1%, everyone with cirrhosis, CHF, etc., CHF, it would not come anywhere near close to the 8% of the population. So obviously this is not an illness, but it is a special facet of the population that we have to deal with, much in the same way that we may think about particular clinical conditions. And in addition to having millions of people in that category, we have some households which are linguistically isolated, and that means that no one in the household speaks English well. And most commonly, those are the Chinese, Korean, and Vietnamese. Among the Spanish households in national data, 22% of the households are linguistically isolated, but among poor people, immigrant populations, that number rises to be as high as 37%. Why do we care that a household is linguistically isolated? Because if you're not linguistically isolated, you can say to your family member who speaks English, hey, can you make me the appointment in ophthalmology? If you are linguistically isolated, it is extraordinarily difficult to make that appointment unless, of course, the system is set up to receive it. So with that, let me turn, sort of general background, let me turn to what do we know about language barriers and patient-centered outcomes. And I want to focus on 3. And the chief of those is, not chief of those, but first, I want to talk about underuse of interpreters. I think anyone who functions clinically, particularly on the inpatient setting, knows how common this is in the real world. And I'd be interested to hear your own reflections on your own clinical setting. There are no national data that tells us whether or not patients are getting interpretation in the hospital. This is probably the biggest data gap in this field. And when you look at studies, the numbers are all over the place, depending on how the question is asked. In our own setting, we have about 20% of patients, not at the general so much as all the UC hospitals, that complain of not having had sufficient language access. And this is, and we have prize-winning interpretation teams and a high level of consciousness around these, relatively high level of consciousness. So I would set the number of 15-20% for hospitalized patients as somewhere around the floor for what's happening nationally. But this is something that, as I say, there are no data. What I'm going to show you, this is an old study of mine that unfortunately has been repeated several times with the same findings. We looked at bedside invasive procedures, thoracentesis, LPs, paracentesis, and compared LEP patients with English-speaking patients and matched for age, for the underlying diagnosis, type of diagnosis, and the procedure, month and the month. And what we found is that there was more consent in a form in English, in the English-speaking patients. Only 22% of the LAP had a consent form in their language. And in terms of full documentation, a procedure form and a consent form in the patient's languages, there were large gaps. Now, there was large room for improvement among the English speakers, a constant theme you'll find in what I'm going to say, but nonetheless, large gaps. We have tried to address this in many ways, including stapling a checklist to the, every procedure kit. But nonetheless, the hospital has repeated this, and the results have improved somewhat. There's still a very large gap. And in fact, our main, the UCSF main hospital at Moffitt was cited 2 years ago for informed consent. Insufficient documentation of informed consent. Why am I telling you, why am I washing dirty linen in public? Because this is these are the sorts of things that motivate change. And because I believe that we have very strong house staff, very strong hospital, a terrific hospitalist community of physicians. And I think that we represent probably at least an average, if not a best case of what's going on. JCHO is now examining informed documentation of informed consent for people with LAP as one of their criteria. So why don't we use interpreters? We did a study with our own residents and residents at Yale New Haven, and the results were pretty much what you would find. There's a hassle factor of calling an interpreter versus sort of what they called getting by. And it wasn't that they were forgetting, they just made a decision to, that it wasn't worth it. And what they would explain to us is that if it was a high stakes conversation, chemo, no chemo, anticoagulation, no anticoagulation, DNR discussion, that of course they would get an interpreter. But if they were just rounding, then they had to make that calculation and decide whether it was or not it was worth it. Only one of my articles to make the New York Times, so I show off here. So I know that physicians are very pushed for time. They may or may not call an interpreter. They may just get by on the few words they know for different languages, like for pain, and take a deep breath and just fumble through. What was clear to us from how they talked is that underuse was normalized. I hate to say it, but interacting without an interpreter doesn't bother me too much. I guess I feel like someone is talking to him and getting a good history at some point. So it's okay if I come in and do a little bit more of a perfunctory exam in history, knowing that I will at some point talk to them with an interpreter when time is available. But in some ways, it does not seem all that fair. That was then. We repeated the study. Procedural consents, more people are getting an interpreter. This is self-reported data from our residents, not that long ago. But what they see is that in things like daily rounds, about 45% tell us, I get by. I go in, I say tong, tong, which is pain in Cantonese, and move on. As you all know, there are health system contributions to these difficult choices that we make because of a lack of investment in interpreter technology. And there's also a lack of policies within hospitals. We'll come back to that. This is an area where JCHO has not set policies. In other words, while the class standards say all patients are entitled to interpretation, there isn't a real clear standard on what does that mean? And how can a hospital be measured on that? Nor is it a reporting requirement for JCHO, though it has been under discussion, and pre-pandemic it was one of the things on their agenda. And then finally, I want to say two things. One is that there's a general acceptance that that it's okay to skip this on the part of lower quality of care, but also that the movements toward improving interpreter services have unfortunately generally come from lawsuits in our own hospital, but in hospitals throughout the country who have robust interpreter services. You say, wow, your interpretation services are so robust. How did you get there? And they say, well, we were sued. Okay, point number 2. Interpreted conversations, which we all have to have, are unfortunately much less good than one might think in terms of patient comprehension. So the best study that I find for that is one that isn't mine. It's actually out of Bellevue, and is where someone was very interested in comparing 2 state-of-the-art interpretation systems, a remote UN-style interpretation with simultaneous interpretation, and an in-person interpreter. So there were 2 state-of-the-arts. And so what they did is that as patients came into the emergency room, if the patient happened to see a language concordant doc, fine. But if they didn't, they were randomized to one of these 2. And then as all the patients left the emergency room, they were asked questions. Did they understand the doctor's explanation of their condition? And also, did they understand the care instructions? And what you'll see here is the difference between the 2 systems is trivial, but the difference between the 2 systems and language concordant physicians is quite high, with these being in the 60% and the others being less than 40. What did this teach me? It taught me that even with state-of-the-art interpretation, we know these patients got interpretation. We know that these interpreters are highly experienced and wonderful, that people still understand much less when they're working through an interpreter. And we can come back to that because I think it has to do with the patient's ability to ask clarifying questions. Now you can say, look, they didn't understand that much. Many of people didn't understand with a language concordant doc. And in fact, that's true. And here, Bellevue, as you know, is a city hospital, lots of poor people with low health literacy. And many of our patients don't understand our explanations or understand our instructions. And so we have a lot of work to do with everyone. But nonetheless, it is clear to me, and many other studies confirm this, that comprehension suffers. And that's probably one of my important take-home points from a clinician's point of view. In one of our own studies where we surveyed 1,200 people with 10 languages, we found that patients who had LEP reported more trouble understanding a medical situation than patients who were English proficient from the same ethnic background, even when they're using a language concordant doc. Why is that? It reduced the number of people who say they didn't understand, but still it was quite high. Partly it's because medical situations are much more complex. So that's the data. My interpretation of this is that medical situations involve multiple touch points. It's not like you see one doctor and the nurse doesn't explain things, or the MEA doesn't explain things, or you don't see. So you see, medical situations are complex. They involve multiple connections. So having a primary care doctor is wonderful and helps reduce not understanding. But nonetheless, there are very high rates of not understanding a medical situation. And then finally, what many of you have probably observed in your own interactions, that trust and patient satisfaction are more difficult to elicit across language barriers. So here's a study of ours where we surveyed patients, Latino patients with diabetes in the Kaiser system. And when we look, first, I want you to focus on the 2 columns on the left. You can see that it looks like there was no difference between English proficient Latinos reporting a lack of trust and LEP Latinos reporting a lack of trust, or not showing respect. But what and if you only look at people by whether or not they spoke English or not, it looks like the communication patterns are quite similar. But if you take the people, if you take the LEP group and disaggregate them into people who have a language concordant doc and people who have a language discordant doc, in other words, people who have a doc who spoke Spanish and people whose doctor or clinician did not speak Spanish, we see very large differences with language, with those seeing language concordant being less likely to report a lack of trust and less likely to report a lack of respect. Unfortunately, about a third of all of our patients think we don't listen enough to them, and that is irrespective of our language abilities. Why is this? Why is it harder to elicit trust? And I think that what this goes to is that when you audio tape interpreted conversations, what you find is that patients talk less and we talk more at them. And we're much less likely to elicit their point of view. So if I'm taking care of a patient I just speak no Cantonese, or someone who's Cantonese speaking with diabetes, I'm very focused on the metformin is twice a day and the high blood pressure medicine is once a day. And you also have to take the cholesterol pill every night. And then when I go over that again, I'm trying to make sure that the patient understands me. That's great, terrific work. But I'm much less likely to say, so how do you feel about taking these medications for your diabetes? Before you didn't have diabetes and now I have you on 4 medications. How do you feel about that? Let's talk about that. And this less likely to elicit the patient viewpoint happens is very clear. And it means that we don't get what their concerns are or what their questions are, because we're so dominating the conversation in a biomedical, in a strict biomedical comment. The other thing that happens is that we make far fewer empathic remarks. So I had I was observing one of our residents, and he was working with an interpreter, with a patient with an interpreter, and he was looking at the computer and he said, oh, I see you missed the chest clinic appointment with the lung specialist. And the patient, through the interpreter, said, yes, my mother died. And the physician turned back to the computer and said, I will make you another appointment. Bad resident? No, great resident. I've observed him in other interactions. But it becomes almost this, we're just going to say the things that matter, defining matter as getting the business of medicine done. We know from studies with very diverse patient populations, including Black African-American populations, that it is precisely these failure of empathic moments that are very common in cross-cultural relationships. And it is these empathic comments that lead to, that are associated, let's put it this way, with higher trust building. It is also the listening to the patient, the elicitation of the patient's point of view that is elicited, that is associated with higher trust building. So this is why I think trust is consistently reported as lower and patient satisfaction is consistently reported as lower. And for reimbursement, that is dependent on patient satisfaction, training people in this may be, the experiment has not been done, may be one way to go if you cannot shift people to language concordant providers. I always, I'll move on from this, but I always tease the residents tease me that I spend all of my time talking to their patients about their families and this and the other. And then at the end I say, oh, by the way, I'm raising your metformin. And that's not quite true, but it is true that patients, and I don't have to tell a group of generalists here, you're all experienced clinicians, that patient to the it's the extent to which patients feel cared about that establishes good. Yes.
Just thinking out loud here, to me, this is an opportunity to combine not only each other, but also our generally lost among our trainees. Because I'm certain we're better than this. Almost closer to like family members. So I'm sure I'm not good at this. How to care people I don't know. But I think people I do know, I bet I know better at this. So I think, I don't know, I think it's just an opportunity. One of the values of continuity is that you do a better job.
Thank you. I think that's an extremely important point, and I completely agree with you about, yes, which is about that in a primary care relationship, we do a better job in this than we do with episodic care, no question. But I'm describing primary care relationships. These studies are done in primary care, where people have been with their doctor. Like that Kaiser study was, I think it was between 3 and 5 years that people had been with their doctor. So it is really, it's still pretty amazing. And if you, unless you're a physician that pays attention to this, if you ask yourself, what do I know about this patient's social history that I have to take through a language barrier versus that patient's social history where I can quickly ask the question or the patient will comment and I will understand it. Oh, I was just here yesterday. I had to bring my husband in for a, whatever. Then it's more difficult. And so I think that what this speaks to, and I think it's you have a great point about reminding trainees. I completely agree. And I also remind myself, do I really know the social history of my patients across these language barriers? Do I make them feel that I care what they think about their illness? Do I get their point of view? And do I make sufficient empathic remarks? And sometimes, doing that much more consciously has been a great help to me in my own care. So, how then does all of this fit in? What are the clinical implications? One, there's lots of literature on multiple worse outcomes. For example, more medication errors, more likely not to understand prescription labels, far less likely to know what their medications are going to be at hospital discharge, and less likely to know about follow-up appointments. And this is where you can see that LAP patients often have more fragmented care, even in systems that make it easier not to be fragmented, like a Kaiser system. And because of all of this, language barriers have been implicated in patient safety, not only in terms of timeouts, but also in terms of doing things like remembering to check again about allergies instead of just relying on chart lore. There are, however, specific clinical outcomes that are worse with language barriers. And here is some of my own data, also from Kaiser, study of 20,000 patients, 5 languages, survey study. And what we did is we looked at Latino patients, English-speaking Latinos, non-English speaking Latinos. The patients were fairly similar in age and gender, but quite different in that 70% of the LAP had less than a high school education, whereas 70% of English speakers had a high school education. So education is a fellow traveler with language barriers, and then so is income. However, when we looked within those that were LEP, it looked like they were just, whether they had a Spanish-speaking doctor or not, it looked like they were pretty much randomly distributed. And then when we said, well, what is their glycemic control, A1C over 9, we found that among the white English speakers, 10% had very poor glycemic control, 18% of the Latino English speakers, and 21% of the LAP. When we disaggregated the LAP, this 21% was very misleading because it was actually only 16% of those who saw a Spanish-speaking doctor and 27%, 28% of those who did not. Okay, interesting. But cross-sectional study, it can be subject to a lot of, and here are the odds ratios, and they show the same thing. They can be subject to a lot of confounding. After all, maybe a patient who has their act together more seeks out a doctor who speaks their language. So we're not going to have a randomized trial of this because there is no equipoise in that patients prefer a doctor that speaks their language. So how could we deal with it? We looked at a natural experiment, but first let me tell you that we did not find differences in the same cohort around cholesterol control or blood pressure control. The differences we found were in a glycemic control. So what we decided was to look at switches. And we did a differences in differences study where we looked at all forms of switches, from discordant doctor to concordant, discordant to discordant, concordant to discordant, etc. And the only switches that made a difference, we looked at their hemoglobin A1C 1 year out. See what a much higher proportion of people were in glycemic control, defined here as under A1C under 8, if they switched to a language concordant doctor. And at the end of the year, far fewer people had an A1C over 9, 13% less, if they switched from a discordant doctor to a concordant doctor. I hope I'm explaining that clearly. None of the other switches were statistically significant. And when suppose you can say, well, maybe they're switching because their glycemic control isn't that great. We did a subset analysis looking only at patients who had a forced switched because their doctor left Kaiser, and we found the same point estimates. It wasn't statistically significant because of smaller size, but it was the same point estimate. What did this mean to me? It means that one easy way to improve your glycemic control is to ask your patients in a panel whether or not they would like to switch to a doctor that speaks their language. Patients fear the unknown. Some of them will say no, but facilitating language concordance from the get-go and asking people who are not doing so well whether they would like to switch is a panel management strategy. On the other hand, while this may look significant, it wasn't. Systolic blood pressure improved with everyone, and cholesterol improved with everyone. And why is this? It's because the people who needed the help were people for most likely where a medication had fallen off their list. Oops, you're not taking that statin. Yes. I'm so happy you asked that, and I think I have a slide about that. But the answer is that in the Kaiser system in Northern California, people are not. Let me just see if I have that slide. No, sorry about that. In the Kaiser system, people are not. Clinicians in Northern California are not tested. In Southern California, people are tested and recompensed. They earn more if they speak Spanish. That's because LA is like unbelievably Spanish speaking. But we have done studies showing, asking if physician self-report is sufficient. So I'll do it now. You have a choice. Let's ask about Spanish. You can self-assess as speaking no Spanish, poor Spanish, fair Spanish, very good Spanish, or excellent, okay? So how many people speak no Spanish? How many speak poor Spanish? How many people speak fair Spanish? How many people speak very good Spanish? How many people speak excellent Spanish? Oh, we need to get more language skills. Usually, it wasn't the modal category here. The modal category in California is fair. Now, if I ask all of your patients, does your doctor speak Spanish? We've done this. If the doctor answered no or poor, the patient says, yeah, my doc doesn't speak Spanish. If the doctor answered very good or excellent, the patient said, my doctor speaks Spanish. But if the doctor answered fair, the middle category, the modal category, the patient split about 50-50. And that is because fair is a really broad category. And so fair are the people who are dangerous. That's the people who, as physicians, you all know, we tend to overestimate our language ability, right? We tend to overestimate our abilities, right? We overestimate our abilities to read ECGs. We overestimate our abilities to hear murmurs and so on. The literature is quite clear on this. We are not underestimators. We are overestimators. And unfortunately, with our language abilities, it's the same thing. And so we may feel like we can say things to a patient, and we may have enough of a second language to be able to talk to a patient, and yet not enough of a second language to understand when the patient speaks back to us. And why? Partly because low literate patients often use more less standard terms, and because unless you have very good Spanish, it's easy to make a mistake, particularly in tenses, and not being able to get the history of what happened when. So with all of this, you would think, okay, adherence is different, must be different, right? Look at that, they got better. And yet what we found is that while LAP had less good adherence, this again is based on Kaiser data, than English-speaking Latinos and whites, it wasn't that different by language concordance. So if it wasn't that different, why did they have better glycemic control? And I would posit that there were two issues. One, a willingness to initiate insulin. As you know, for some patients, that's a big step, and it requires a lot of trust and a lot of talking. And that, I think, happened more in a language concordant relationship, and two, increasing counseling on diet. So defining language concordance, I did have it. This is the Kaiser HR survey. They asked about proficiency in Spanish, speak, read, write, and then this category of just rank your medical proficiency. The only category that had over 80% of the patients agreeing is that if somebody ranked their medical proficiency as high, almost 90% of patients agreed, my doctor speaks Spanish. But for the moderate category, again, it was between 50 and 60%. So in general, we know now that there are greater difficulties with comprehension and trust, and the use of teach back, the use of other ways to check comprehension is recommended. And again, we've talked about the other things, empathic statements, eliciting the patient point of views. We did this very nice little study where we looked at patients in San Francisco who in year one of the pandemic had underwent case investigation and contact tracing. And what we found is that the Spanish-speaking contact tracers were much more effective than the English-speaking contact tracers, as measured by whether or not the contact went and then themselves got tested. So this is a big deal. This means that just by having those language skills, we can get to an actual clinical outcome that we care about. So how do I put this together in my own work? Well, when I don't understand what's going on with someone, like I really don't understand why we're not improving chronic disease management, or I really don't understand what this pain is about or something, I will from time to time ask one of my colleagues for a language concordant consult. I'll say to the patient, I want you to see Dr. Kung. Dr. Kung speaks Cantonese, and I want to be your doctor. I don't want you, Dr. Kung, to be your doctor. I want to be your doctor, but I want you to see her at least once so that I can see if that would be a better way to explain why we're not, why, whatever, your abdominal pain or so on. And other people do that with me. They ask me to see one time their Spanish-speaking patients. Sometimes it's awkward because sometimes the patient says, "Oh my God, you speak Spanish. Can you be my doctor?" So you have to be ready for that. Or can Dr. Kong be their doctor? But I do ask. But other times it's afforded me enormous insight. All right. So we talked about clinical outcomes being worse. We talked about some clinical outcomes are not worse, easy ones, relatively easy ones. Control blood pressure is not easy, but it's relatively easier than glycemic control. And certainly, take a statin is an easy thing to say, for me to say, and have the Cantonese interpreter repeat. So let's move quickly to two innovations. I'm going to talk about machine translation and machine interpretation. So I am a Trekkie, and even in my youth, I was a Trekkie, and I loved this machine. This machine was the universal translator, and that's what they called it. And when they had this machine, they could understand Klingon. It was so cool, and they could speak, and the machine would speak Klingon for them. And we live in a Tower of Babel, and I would love to have a universal translator. So how close are we to a universal translator? Well, we did a study where we took ED instructions from our own residents at our own hospital, which is, again, a great emergency medicine and program. And we had it translate, we put it through Google Translate, and then we had it back translated by professional interpreters, all right? And this is what happened. It was actually much better than I thought it would. There were only 8% errors in the Spanish, more in the Cantonese, in the written Chinese. But those errors included some very serious errors. For example, here, our very bright resident did something that he or she should not have done, and wrote, "Hold the kidney medicine until you have a chance to speak with your kidney doctor." Hold, tener, hold on. They got back translated to keep the medication for the kidney. And in Chinese, the same thing, keep taking kidney medicine. Hold as in, like, keep going, hold on. And spelling and grammar anomalies like this for medications ended up being completely distorted, and to the point that you could not understand it. So what have we advised? We advise that you should not use Google Translate unless you are using it for very short, direct phrases where you're not using medical jargon or abbreviations, all of which is extremely difficult for doctors. And if you do decide to use it, it should go, there should be a message saying this was machine translated, and the English should be there. And this allows someone to understand that it's the English that is real. Does that make sense? Am I explaining this well? So anytime someone uses a machine translation, there should be an automatic smart phrase that says this was machine translation, and what they wanted to say in English should also accompany the documentation. Yeah.
Right now, if you want to do this, you write it in English, you cut, paste it, Google Translate, cut, paste. Is there really an effort to?
Yeah.
Directly in the EMR?
Yes, the question is about machine translation directly in the EMR. Yes, in fact, we now have it at one of our hospitals in Epic. I don't know if you all are on Epic. So we now have it in one of our hospitals on Epic. I have yet to test it, but we are starting a study where we're going to have professional translators translate, and we're going to have chat GPT translate, and then the professional translator overread for errors. And our outcomes are efficiency translator time and accuracy. And so we think that that may be a way to go with a professional overread. You don't have to be you can see that this is not right. Yes, sir. Make mistakes? Yes, there are, but it is not, there's more data on human interpretation. And I'll show you that right now. The question was about, well, how often do humans make a mistake? When humans make a mistake, it's not this kind of a mistake. Hold the kidney medicine versus keep the medicine. It is a mistake usually more in nuance or in than it is in accuracy. So I'm working with a young anesthesiologist, a faculty member, and he's very interested in using his phone to talk to his patients in the PACU, because it's one of those places you're not having long extended conversations. You need to say, give me a thumbs up, or can you feel this, or something like that. I don't know why they always want to give a thumbs up, but that's his favorite phrase. And so we decided, we put together, I think it was 160 conversations, little snippets between a PACU patient and a clinician. And we looked at Apple interpretation, Google, Microsoft, and human. And then we had assessors who were blinded to all of this. And what we found is that acceptability was always very high for the human, and that English to Spanish varied by which one, but they were less than 80% acceptable and did not cross a non-inferiority barrier, meaning they're inferior to the human interpreter. But English to Spanish wasn't bad. English to Mandarin was a little worse, but still not horrible. But Spanish to English and Mandarin to English were terrible. What does this mean? That we can talk at our patients, but not hear our patients. So in Spanish, ¿por qué could mean a question, or porque yo soy así can mean because. And the machine could not distinguish. And so it doesn't rely on the tone. It relies on the transliteration of the word. So we had phrases coming back, because my leg hurt, as opposed to, why does my leg hurt? So I'm going to wrap up policy recommendations. We are recommending 1 conversation per day with physician for all hospitalized patients, documentation of that. Didn't get it. We now are running a pilot in our on one of our hospitalist surveys. Why did we not get this at the main UCSF hospital? Because they said it would add a documentation burden to the clinicians. Document 1 conversation per shift with nurse. They do 12-hour shifts. We didn't get that either. Stratify for our QI people, we're asking that people stratify by language, and then ideally also by language concordance, because as you saw in our data, those are really different. And so we want this in our data, and we want any dashboards to include limited English proficiency as a primary category. Everyone who uses a second language should pass a test and be compensated, much as in the same is our thought on that. And obviously facilitating language concordance in outpatient care. One of the questions I get frequently is, does training help? If you train people to work with interpreters, do they do a better job? And the answer is yes. And it doesn't take a lot of training, less than 8 hours. We are using patient report. We do call our patients after discharge. And one of the questions that's asked is about, do they have their medications and know them, but also did they get interpretation services? And so we're using patient report, monitoring informed consent. And then in the ideal world, we believe we should have language concordant help with our discharge instructions, so that at the moment of discharge, probably the most perilous moment for a hospitalized patient, we can get full, the patient and their family can ask questions and really understand the treatment plan. So in summary, I hope I've showed you that language barriers highlight the importance of communication, any communication, to the patient trust and experience of care. That you understand that language concordance is much better than professional interpreters for comprehension and complex patient outcomes. But unfortunately, we all rely on interpreters. And that underuse of professional interpreters remains common and is maybe one of the things we should most be talking to our trainees about. Machine interpretation is not yet ready for prime time, but in the next 5 years, that could really change. And then written policies are probably needed in most places. So with that, let me thank you and ask for thank you for your attention. I hope we have some few minutes for questions. Yes, in the back.
We use a lot of iPad video.
Great. Oh, to in-person? So video interpreters are much better than phone interpreters, much better. And in certain ways, they're better than in-person interpreters. It depends on the situation. If there is a one patient, video interpreters are clearly the way to go because among other things, they allow the patient more privacy because you can turn the video away if you're doing a sensitive exam or something. But in family meetings, it is almost impossible for the video interpreter to keep up when lots of different people are talking, and it can be very confusing, is what our interpreters say. So for family meetings, we recommend the use of in-person interpreters, but for direct patient care, video interpreters are excellent and much better than phone interpreters. Yeah, Matt. Thank you. Right. Yes. Yes, great point. The question is about the amount of time it takes. We have a division of general medicine at Moffitt Hospital, which is where the number of LEP patients is relatively small. It's under at 10%. That division of general medicine now puts every LEP patient into a double slot. We don't do that at the general because LEP patients are more like 40% of our patient population, and we need to maintain access for people. We wouldn't have enough access as it is. We don't have enough access for people in the city. But some divisions are moving toward that. They're saying the only way to do this is to give people more time. And that's not that different. In my colleagues in geriatrics get a lot more time with the very same patients that I'm seeing not in geriatrics. And it's a little bit of a recognition of the reality of care and a way of ensuring better care. To the extent that we move to value-based care, if we move to value-based care, and have a reimbursement system that rewards us for well-controlled chronic disease and so on and so forth, I think it'll be easier to get more time. To the extent that we're now judged and rewarded on, well, how many patients did you see? It will lead to physicians avoiding LEP patients, which already I have plenty of evidence from in other systems. Mark.
About our workflow, and if everything goes well, LEP patient scheduled to see me, I walk in and the video interpreter is already set up. So it's screened, and we know that, and the
yes.
workflow is there. I suspect that a lot of this is because somebody walks in and it's not set up, and there's the time involved, and so that's when you just get by. Are you aware of like some best practices?
Yes. Yes, the question is about best practices for use of interpreters in the outpatient setting. So I want to be clear that the data I showed on underuse of interpreters is from the inpatient setting. In our outpatient setting and in many outpatient settings in primary care, interpreters are used most of the time. Certainly in our setting, I would say it's close to 100%. In our specialty clinics, if the interpreter has brought a family member, then sometimes those physicians will cut corners and use a family member, which obviously is not what we recommend. But I think that to answer your question about workflow, I think that it is the more prepared the system can be, sort of Wagner model, chronic disease model, the more the patient is pre-identified as needing an interpreter, the medical assistant has set up the interpretation, all of those things will make things go easier. And so I do think that that is quite important. Yes. English. Yes. Yes. So this comes up all the time. What about patients who don't want an interpreter? I say and that happens a lot. I have Hindi speaking patients or Tagalog speaking patients who speak, some English, and they're like, I'm okay. And I said, I know you're okay. It's not for you. It's the hospital rules. This is for me. Let's try it and then we'll see. That's what I say. Am I forcing them? Yeah, a little bit, because it's my clinical judgment that we need an interpreter. And then what happens is that they like it. They like it. And it's a little hard on the interpreter, but they understand, because sometimes I'll ask something and the patient will answer me without waiting for the interpreter. But on the other hand, it gives all of us a chance to gauge, do we like it or do we not like it? Yes.
Can you comment on the training or innovation around the interpreter? Again, it's like there's interpretation and there's translation. You translate word for word. I feel like interpretation is like, say, you're active members of the team uncover that concept that I'm trying to get out of the patient, as opposed to just doing word for word. I mean, there things role practice innovation on the other side rather than.
Yeah, very interesting question about the difference between interpretation and translation and what is the proper role of the interpretation of interpreters. So first, let me say, interpretation refers to spoken word and translation refers to written word. And so all professional interpreters are taught to interpret word for word. They don't always do that. And there are plenty of studies on that. Someone asked about mistakes and so on, omissions and additions and so on. But what you're getting at is the interpreter is a member of the healthcare team. And during the pandemic, in a lot of places, that became more apparent how important the interpreter was as a member of the healthcare team. And one of the things that we moved to some years ago in our hospital is that our professional interpreters all wear short white coats. They all identify themselves as a member of the healthcare team. And they always say, of course, that they have to keep confidentiality just like the doctor. Every interaction, every time. And then when I want the like I'm not getting something, I will sometimes say to the interpreter, I am confused about whether this happened now or whether this happened, whatever. And can you find out for me? And the interpreter will say yes. And we'll turn and we'll talk back and forth with the patient until the interpreter is clear. Very difficult, for example, if patients with dementia or patients with psychiatric disorders, terribly difficult, huge role for language concordant doctors. One of the areas where I most call for a language concordant consultation. But you can use interpreters that way, particularly if with a we're going to go in and talk to the patient about end of life, with a pre-visit, by including them in the team as they deserve to be included. So yeah, great. You can do that. There's no reason you cannot do that. Well, we're at time, I think. Thank you very much. I appreciate all the questions. Oh, thank you. You think people learn something?
Thank you very much.
Thank
Nice to meet
you.
Yep.